All right. All right, let's get started, everyone. Today is Thursday, November 30th. Hope everybody had a good Thanksgiving break, at least a couple of days or hours of break. So today is one of our popular CPC cases led by our internal medicine chief residents. And today, to get started, this case is sponsored by or moderated by Dr. Pat Willard. So I'm going to just jump right in because we have a busy hour, so we want to get started. Pat Willard is one of our current internal medicine chief residents. He focuses on medical education and is the main conference chief for the program. He's from New Jersey and graduated from Rowan University School of Osteopathic Medicine in Stratford, New Jersey. And he plans to continue his training in Hem-Onc, and I think he will share with us that he did match here at VCU. So let's give Pat a big round of applause. We're really excited to have him here, stay here. So if you want to come on up and get us started here, talk about the CPC and introduce our speakers. Thank you.
Awesome. Thank you, everyone. I'm going to bring up my slides here. Oh, great. Cool. So thanks for everyone for coming. I have a really awesome case I'd love to share with all of you here and some great speakers for you all. So I'll just go ahead and get started. So today the format is going to be introducing the case, a discussion and dissection, content and expert discussion, as well as a Q&A session at the very end. So the objectives is to identify key components in the patient's presentation and determine what is relevant in the history, exam, and objective data, to generate a differential diagnosis, and then use evidence-based medicine in order to support diagnostic approach and use of critical thinking throughout the process. Okay, so the case is a 34-year-old female. She presents to the hospital due to intrauterine fetal demise and was there for the induction of labor. She was 24 weeks gestation when she began to have urinary frequency, dysuria, dark urine, and occasional intermittent diarrhea for about 2 weeks. She was evaluated by her OB, who diagnosed her with a UTI, but subsequently found absent fetal heart sounds and referred her to the ED for induction of labor for IFD. Due to abnormal labs, the patient was seen by the medicine consult team. So 2 days after delivery, she notes improvement of her dysuria after treatment with ceftriaxone. Her only remaining complaint was mild abdominal cramping, and on further questioning about her diarrhea, it was intermittent and watery for 2 to 3 weeks, but has resolved prior to the submission. She denied any fevers, chills, melena, hematochezia, abdominal pain, nausea, or vomiting. And generally, the review of systems, she denies any weight loss, any night sweats, fevers, or chills, denied any chest pain or orthopnea, PND. She did not have any dyspnea on exertion or cough. She had some lower abdominal cramping, but denied any blood or dark stool. She had minimal vaginal bleeding, but did deny arthralgias or joint swelling, and she did not have any rashes or bruising. For her medical history, she has a history of migraine headaches as well as a kidney stone 8 to 9 years ago. Her past surgical history included wisdom teeth removal at the age of 18. She has no family history of malignancy, bleeding problems, or autoimmune disorders. And her gynecologic history had no prior STIs of normal PAPs, and she was G1P0010. She had a social history that was unremarkable, denies any tobacco, alcohol, or drug use, no allergies, and only medication is prenatal vitamins. On exam, her vitals was noted for a temperature of 38.3. She had a blood pressure of 141/80, but repeated was 128/77. Heart rate was tachycardic at 123, and she was satting 100% on room air with a respiratory rate of 18. For her physical exam, nothing actually terribly remarkable on here other than having a soft uterus that was palpated without tenderness, and notable that she had tachycardic rate and rhythm, but nothing else that was noted on exam. So for her labs on presentation, this is when she came to the emergency room. Her sodium was 136, potassium 4.1, chloride of 107. She had a bicarb of 17, BUN of 37, and then she had a creatinine of 1.5. Her baseline was 1. Her glucose was 97. Her AST was 151, ALT 61, alk phos was 99, and bilirubin was 1.4. She had a white count of 12.4, a hemoglobin of 10.9, and a platelet that was noted to be 9. She had fibrinogen at 356, a PTT at 25.1, an INR of 0.9, an LDH of 1,616, and a haptoglobin that was undetectable. 2 days postpartum, we repeated labs, and sodium was 138, potassium 3.3. She had a bicarb of 18, and her creatinine rose to 1.7, the BUN of 34. She had AST was 156, ALT was 44, and she had a total bilirubin of 0.6. Remarkable for a CBC was a white count of 14.5. She had a neutrophil predominant differential. Her hemoglobin dropped to 7.4, and after 2 platelet transfusions was up to 44 for her platelets. She had a INR of 1.0, an LDH of 1,521, and still an undetectable haptoglobin. Her reticulocyte count was elevated at 15.1%, and she had a DAT that was negative, and a smear that was remarkable for polychromasia, anicytosis, ovalocytes, immature granulocytes, and numerous schistocytes. Her UA had leukoesterase that was trace, no nitrates or glucose, and she had red blood cells that were 10 of them. White blood cells was 9. Urine protein creatinine ratio was elevated at 34.4, and she had a negative anticardiolipin, a beta-2 GPI, and syphilis antibodies. Her parvo B19 antibody IgG was positive, but negative IgM, and her blood cultures were negative. Her renal ultrasound was remarkable for echogenic kidneys with mild fullness in the right renal collecting system without frank hydronephrosis, small perisplenic fluid, and no evidence of cardiopulmonary disease on her chest X-ray. So that being said, I'm going to get started and announce our case discussant. So Dr. Laura Paletta-Hobbs is an associate program director of internal medicine at VCU. She obtained her BS in biology and psychology, and her MS in physiology at VCU as well, where she stayed to complete her medical training. She stayed at VCU for residency and completed a combined program in internal medicine and pediatrics, and served as a chief resident, and then joined faculty as an academic hospitalist. Dr. Paletta-Hobbs has a passion for medical education and is a distinguished medical educator, having achieved several awards, teaching and holding several positions as a core educator for internal medicine residency program. She has served as an advisor to several internal medicine residents for over 10 years as a hospitalist director pathway and as the associate program director in clinical competency. Her specific interests include evaluation and feedback, competency-based medical education, mentorship, and coaching. So I am proud to announce up here Dr. Paletta-Hobbs.
Well, thank you, Pat, and hello, guys. I'm really excited to discuss this patient with you today. So, okay. So my objectives, you're gonna have the opportunity to observe one clinician's approach to diagnostic reasoning using an unknown case. I'm going to review the systems of thought used in clinical reasoning. I want you to consider the potential for cognitive bias and diagnostic error. And lastly, we're going to embrace uncertainty with grace, humility, and a growth mindset. I have no disclosures. So back in the Kessler lecture for Grand Rounds, Dr. Hallowell said, if you put artwork in your presentations, people will think you're smarter. So I took a page from him. This picture is entitled Self-Preservation. And actually it was created by one of our PGY3 residents, Nicole Hawkins. And it speaks to me. When I was at the Academic Internal Medicine Week conference 2 years ago, one of my educational role models, Dr. Kimberly Manning, got up and addressed her imposter syndrome. Dr. Manning is a full professor, and she speaks countless times a year. And so it was really powerful and reassuring that if someone so renowned has imposter syndrome, why wouldn't I struggle with that? So taking a page from her, I'm going to address my own imposter syndrome. So, dear friend, I know that you don't think you belong here, as you have successfully hid from every chief resident who has tried to ask you to do CPC. But it is time. You know what you're doing. You've put in the work, and you deserve to be here. So let's go ahead and do this and have some fun. Yes. Thanks. And lastly, full disclosure, I am not 100% certain that I have the right diagnosis today, and that's okay. Every internist gets cases wrong on the first try. What's really important here is that I discuss my thought process and tell you when I have uncertainty. Okay. So it wouldn't be CPC if I didn't go over the dual process theory or how we go about thinking and making clinical decisions. So 95% of the time we are using system one thinking. It's reflexive, relies on our experience and pattern recognition, and as well as heuristics or mental shortcuts. And it's really important if, it's the thought process that you use when you see a bus coming to get out of the street. So it's self-protective. However, because we use mental shortcuts, it is prone to error. And when you don't have enough knowledge in an area, you really can't rely on this thinking. That's when you switch to system two thinking. That's more deliberate and measured. You're using a methodical approach. It takes a longer time and takes practice, but it ensures that you're not missing anything. Okay. So when I approach a case, there are a certain number of steps I go through. So when I'm looking at the data, I'm looking for pieces of information that trigger related information. For example, if our patient had orthopnea and dyspnea on exertion, I'd be thinking, oh, I want to hear about crackles and JVD and to support the diagnosis of CHF. I use the data that I get to make a problem representation or a summary statement and generate hypotheses using the endless scripts that I have cultivated over my years in medicine and compare with the problem representation. And then ultimately I reach a diagnosis. So a problem representation, just as a review, is a one-sentence summary that highlights the diagnostic features of a patient's presentation. It's used to generate the differential diagnosis. Namely, it's the who, when, and what of your patient. It's the description of your patient, including pre-existing conditions or predisposing situation. It's the when, the temporal pattern of illness, and then the clinical syndrome or what their symptoms are. We can refine it using semantic qualifiers, words like acute, chronic, intermittent, progressive, and this helps you compare it with illness scripts as you go. Illness scripts are the description of disease states that you have on your differential diagnosis list. This also involves a predisposing condition, sometimes a pathophysiologic insult, and then the clinical consequences or manifestations. I like to think of them, I don't know if everyone is old enough in this audience to know what that thing on the left is, but I like to think that I have a giant Rolodex in my head full of cards with all of the diseases I've come across. Okay, the last thing before I get to the case. There were some guiding principles that I used when I was doing this case. One, our patient is a pregnant woman, and there is an entire residency worth of information that I don't know about OB. So because CPC is sponsored by the Department of Medicine, I'm going to focus on the internal medicine and ignore some of the OB. In real life, our data acquisition is really unlimited if we know what we're looking for and how much we want to ask a patient. But here, it was distilled down to 1.5 pages of information. I trust that everything I need to know is on that protocol, but I don't know if everything on the protocol is actually needed. So it's my job to separate the signal from the noise. And lastly, as I mentioned, the uncertainty, there's a chance I didn't get the case right. And so it's going to be really important for me to verbalize my thought process and show my work. Okay. So here's our case, and I'm not going to read this for you. I think maybe the people on Zoom can read it, but that's not my intention. I'm going to tell you what I think about things. So what do we know about our patient? They are pregnant and they're in their 2nd trimester. They had UTI symptoms and intermittent diarrhea that was treated with ceftriaxone, and her symptoms pretty much resolved after that. She's here for intrauterine fetal demise, and I think this is an important thing. It also lies completely out of my wheelhouse, so I'm going to have to learn something about the causes. Review of systems was pretty negative, as was the rest of her history. It was pretty untelling, except for the things that were included that were negatives. So there was no history of malignancy, autoimmune, or bleeding problems in the family. And she's had no exposure to heparin on her medicine history. I don't know about you, but I rarely put no exposure to heparin when I write down the med list, unless I really want my people to think about something. Okay. Exam, just like Pat had said, it's pretty normal. The vital signs are telling. So she's tachycardic. Although in pregnancy, a normal heart rate goes to 113. She's still tachycardic. She's febrile. She's hypertensive. You would think maybe she's slightly tachypic, but a second trimester pregnant woman can have a normal respiratory rate up to 24. She's not hypoxic. So she has SIRS. She has 2 of 4 SIRS criteria, and she has a UTI. But I think that her SIRS is really being driven by the fetal demise and not sepsis itself. And then she's hypertensive. And so I remember with hypertension, you can have preeclampsia and eclampsia, and I wonder if that's related to her fetal demise. All right. So if we were in morning report right now, we would stop and come up with a problem representation. So we have a 34-year-old pregnant woman in her second trimester who's presenting with a subacute UTI symptoms, intermittent non-bloody diarrhea, as well as an acute intrauterine fetal demise with hypertension, tachycardia, and fever, and an otherwise unremarkable physical exam. Well, I don't know about you, but I don't feel like that's going very well. But then I remember that we were actually called for abnormal labs. So we'll keep going. I did look up the causes of pregnancy loss in the second trimester, and I have them listed up here. But following my first rule, I'm going to ignore that total first line of causes. Infection is a possibility, and E. coli, group B strep, and enterococcus are all UTI pathogens. So I wonder if that's related. Hypertensive disorders, so chronic hypertension, which is developed before the 20th week of gestational age, can cause it, and so can preeclampsia. And then maternal medical problems like diabetes or lupus. She doesn't have those. However, every patient does have a first presentation for a condition. So just to keep that in mind. So when you Google what causes dark urine, you get an entire spectrum of color wheels of urine and what the possible causes are, as well as several admonishments to drink your water. And I'm going to take this. But what can cause dark urine? So certainly dehydration, infection can cause dark urine. When you have liver disease, your urobilinogen will be high, and that can cause dark urine. Rhabdomyolysis, other hemolysis. And we weren't really given a good description, so that last test tube on the right could be kind of red and dark. Less than frank hematuria, and then some medications in the same vein. All right, let's go back to our patient in these labs. So looking at the lab, she has a non-anion gap metabolic acidosis and acute kidney injury, stage 1. She has elevated liver enzymes, especially an AST that is 3 times the upper limit of normal. But and she has a leukocytosis. You might think she has anemia, but again, she's pregnant, so the lower limit of normal is 10.5. But nobody can argue that she has low platelets. Her fibrinogen is normal, her coags are normal, and she has evidence of hemolysis with an LDH of 1600 and an undetectable haptoglobin. Okay, here's my system 1 thinking. So she has a pregnant woman with hypertension, fetal demise, and hemolysis, elevated liver enzymes, and low platelets. Well, isn't that help? Like, that's what the letters stand for. But, and I don't know that there actually is a cognitive bias that is called this, but I feel like there's a CPC bias or a morning report bias where you automatically know that that can't be that simple because we're talking about it. So I think that's too easy for CPC, and it's time for us to slow down and use our system two thinking. But first, let's look at our other labs. So 2 days after delivery, she still has an AKI and it's slightly worse. She has stable elevated liver enzymes. She has a worsening leukocytosis and has a worsening anemia, and her platelets responded to transfusion, but are still low. Her peripheral smear shows numerous schistocytes, which I think might be a big clue in this case. Her direct antiglobulin test was negative. Her reticulocyte count was 15.1%, and her coags were normal still. Her fibrinogen's normal, and again, she still has evidence of hemolysis that we saw before. Then other labs that we got, and I think these are the ones that are going to help us narrow down our differential. Her anti-cardiolipin and her beta-2 glycoprotein antibodies were negative. Her syphilis is negative. That doesn't ring any bells, except for the fact that it is CPC, and it wouldn't be a CPC if we didn't talk about lupus and syphilis, right? So her parvovirus E19 IgG is high, but her IgM is negative. Her blood cultures are negative. Her UA is pretty bland, except for the proteinuria, and she does have a fairly significant proteinuria at 34.4, her protein to creatinine ratio. Her FeNA is less than 1. Her renal ultrasound shows, it was really not telling to me, and I'm not really sure what to make of it. I was thinking, well, if they gave us the anti-cardiolipin antibody and the beta-2 glycoprotein, how come they didn't give us an ANA or lupus anticoagulant? And also, the parvovirus seemed a little unusual for me. Also, this UA I don't think would trigger a reflex culture, but I wonder what if there was a urine culture for the initial UA. She did get treated for a UTI. And her did she have a pathogen panel, a GI pathogen panel with her diarrhea? Those would be helpful. All right. So schistocytes, they did excite me when I saw them. And, you know, I think when I see schistocytes, most of the time it's something pretty bad. So the word schistocytes comes from the Greek, meaning broken or cleft. And that's exactly what schistocytes are. They're fragmented red blood cells, and they get fragmented when they get sheared in the microcirculation. We call this a microangiopathic hemolytic anemia. All right. So I think we have more information. We can retry this problem representation. So we have a 31-year-old pregnant woman in her second trimester with resolving UTI and diarrheal illness who presents with acute intrauterine fetal demise, hypertension, and SIRS, an unremarkable physical exam with acute kidney injury, elevated liver enzymes, microangiopathic hemolytic anemia, and a severe thrombocytopenia that persists 48 hours after delivery. All right. So when you have the constellation of thrombocytopenia, microangiopathic hemolytic anemia, and organ injury, that's a syndrome that is described as a thrombotic microangiopathy. And so the epithelium in pregnancy is altered. There could be an injury in other cases. And depending on what the cause is, some other offending agent will interact with the endothelium and form microthrombi. So in HELP, it's an imbalance between angiogenic and anti-angiogenic factors. In TTP, you have these very large von Willebrand factor multimers that cause the shearing of platelets, shearing of red blood cells, and cause the platelets to form microthrombi. And in HUS, you have uncontrolled complement activation. So we're getting at our differential now. And the things that I want to talk about today, so preeclampsia with severe features, hemolysis, elevated liver enzymes, low platelets, or HELP syndrome, thrombocytopenic purpura, or TTP, and hemolytic uremic syndrome, or HUS. But there are other conditions that also have features of a TMA, things like autoimmune disease and catastrophic antiphospholipid antibody syndrome, disseminated intravascular coagulation, systemic infection, malignancy, organ or stem cell transplant, and severe hypertension. And for purposes of time, I'm not going to talk about those last three because they have nothing to do with our patient. All right. So HELP is on the spectrum of hypertensive disorders of pregnancy, and it's on the more severe side. You start with preeclampsia, and you have gestational hypertension, proteinuria, you can have acute kidney injury, your liver enzymes can be elevated, or you can have right upper quadrant pain that isn't explained otherwise. Eclampsia is when you have all of that, plus a seizure or coma. And then HELP is, like I said, the most severe end of the spectrum, where you have elevated liver enzymes to 2 times greater than the upper limit of normal, thrombocytopenia, and you have this thrombotic microangiopathy. It's important to know that HELP syndrome can occur without the hypertension or proteinuria, and so it is also considered its own diagnosis. So I like this still. I'm going to put a pin in it. Okay, let's talk about TTP. So you all probably recall from med school the classic pentad of TTP: AMAHA, thrombocytopenia, neurosymptoms, fever, and acute kidney injury. It's important to know that that complete pentad is actually pretty rare. Less than 5% of people will have all 5 things. But it's important to think about TTP when you have someone who has a severe microangiopathic hemolytic anemia and thrombocytopenia in a previously healthy person. Initial symptoms are kind of vague: fever, fatigue, dyspnea, and bleeding. And it often affects the neuro and GI systems. So from CNS, you can have a mild headache or confusion to something more severe, like a coma, stroke, or seizure. And it's 1/3 of patients have severe neurologic symptoms, 1/3 of patients have mild symptoms, and 1/3 of patients have no symptoms at all. GI-wise, it's also pretty nonspecific: abdominal pain, nausea, vomiting, or diarrhea. Kidney involvement is possible, but it's also usually mild to moderate. And the hallmark lab that you would get is a severely reduced ADAM-TS13 activity. It is a medical emergency and important to initiate treatment right away if we suspect it. So plasma exchange is how we would treat that. So I like this diagnosis too. I'm putting a pin there. So let's talk a little bit about ADAM-TS13. And when I was going through this, I feel like a lot of people before me have called it an Adams T13 test. And so it'd been a long time since I read about it. And I was like, oh, do we all have collective dyslexia for this test? But it is an ADAM-TS13, or we could call it a von Willebrand factor cleaving protein, because that's exactly what it does. When it's deficient, those large multimers of von Willebrand's factor adhere to the epithelium and form microthrombi. This shears the red blood cells and causes microthrombi, and the platelets deposit into those, causing thrombocytopenia. Now, it is important to note that ADAMS-TS13 activity decreases in normal pregnancy, where it will be up to 50% of normal. Also is decreased in preeclampsia, eclampsia, or pregnancy-associated HUS, but it's usually still detectable. But the hallmark, like I said, is severe deficiency in pregnancy-associated TTP, and less than 10 to 20%. Okay, so let's contrast that with hemolytic uremic syndrome. The classic triad of hemolytic HUS is micropathic hemolytic anemia, thrombocytopenia, and renal failure. And it's been classically divided into typical HUS and atypical HUS. So typical HUS is when you have a Shiga toxin producing bacteria, namely the O157H7 E. coli, but other E. coli strains can do that, also Shigella. And you typically have a painful bloody diarrhea. I know you don't always, but I'm going with, I think that our patient for a CPC case might have had the bloody diarrhea. I don't like that quite as much. Atypical HUS is what we've typically called everything else. Some people think that a better name would be complement-mediated TMA. It's caused by uncontrolled complement activation that can be set off by drugs, B12 deficiency, pregnancy, other things. Renal disease is often more severe. Often these patients end up on dialysis. It's thought to be a diagnosis of exclusion. There are complement tests that you can do, but they're not definitive. And so the treatment is aimed at the complement pathway, like with medicines like eculizumab. So I like atypical HUS. I'm going to keep that on my differential too. I think it's important to talk about DIC, or disseminated intravascular coagulation, because it's the leading cause of maternal mortality worldwide. These patients are really sick, and they've usually presented with some severe pregnancy complications like placental abruption, HELP syndrome, a retained stillbirth, septic abortion. And what you have is a consumptive coagulopathy, meaning you get exaggerated coagulation with consumption of your coagulation proteins and impaired synthesis. You get a profuse, uncontrollable bleeding. Labs, you have the thrombocytopenia and schistocytes, but the thing that separates this is you have prolonged PT, increased fibrin split products, and decreasing fibrinogen. And treatment, it involves managing the primary condition and supporting the patient through. Well, our patient had normal coags. So for that reason, I'm going to take this off of our list. I also want to talk a little bit about catastrophic antiphospholipid syndrome. So you need to think about this in a patient who's had multiple pregnancy losses and who presents with arterial and venous thromboembolic events. They have fulminant multi-organ damage from extensive small vessel thrombosis. So they also have a mechanical hemolytic anemia and thrombocytopenia. The antiphospholipid antibodies are present in this diagnosis. So anticardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulant. Now, we weren't given a lupus anticoagulant. So, without it, I don't know that I could totally say that she doesn't have antiphospholipid antibody syndrome. However, we were given a a PT, which was normal. And so lupus anticoagulant is associated with an elevated PTT. So I don't think that this is what we have going on either. All right, so we come to infections that can cause a MAHA and thrombocytopenia. And you can see there are a lot of different bacteria, viruses, fungi, and parasites that cause it. It's important to note that syphilis is not on the list because we were given a syphilis. But parvovirus B19 is. Parvovirus can cause a TMA, and there have been multiple case reports. Typically, these patients have the typical slap cheek rash and arthralgias, and they get an AKI and they have microthrombi that are seen on their kidney biopsy. But our patient had an elevated IgG and not an elevated IgM. So that just means she's had parvovirus in the past. So this is not on my list of diagnoses. So I've narrowed the differential. I like HELP, I like TTP, and I like atypical HUS. The thing that strikes, and this is a list of their features, kind of comparing and contrasting. The thing that struck me first was the degree of thrombocytopenia we had. And you really see that with TTP. And then the acute kidney injury, it wasn't as severe as we would expect with hemolytic uremic syndrome. So again, kind of making me think that maybe TTP is the right answer. The LDH that we had was really high. It was 1600. And so that's consistent with TTP and HUS, but not so consistent with HELP syndrome. So I'm leaning towards TTP right now. And then in the 11th hour, as someone was bringing up new points and making me kind of a little scared about my CPC, I came across the plasmic score. This is a predictive clinical calculator for TTP. So each of the colors give you a point. So we should go through our patient, and I showed you my work. Well, now I can check my work. So the platelet count was 9,000. So she gets a point there. She had undetectable haptoglobin and a reticulocyte count that was high. So she has the indicators of hemolysis. She doesn't get a point for active cancer or solid organ transplant. Oh, she does get a point. Sorry, she hasn't had active cancer or a solid organ transplant. So we're at 4. Her MCV was 92, so she doesn't get a point there, but her INR was less than 1.5 and her creatinine was less than 2. So I calculated her plasma score to be a 6. And a score of 6 to 7 is high risk for TTP. So I'm feeling a little bit better, but I still have that clinical uncertainty. So what about the UTI and diarrhea? I think, the diarrhea could have been a symptom of TTP. We said GI symptoms are present. The UTI was treated and went away, and it's pretty common for pregnant women to get UTIs, but it does make me worried. Did I fall victim to confirmation bias? And I'm just focusing on the things that support my diagnosis and ignoring others? I don't know. And what about the lack of neurologic signs? Well, as I mentioned, a third of people have no neurologic signs. And so I still feel okay about that. But what about that our labs were only 48 hours after delivery and not 72 hours after delivery? Well, they were getting worse. And if we were going to have resolution by 72 hours, we probably would have seen some improvement in the labs. And lastly, I'm sorry, Dr. Kidd, but I didn't know what to make of the renal ultrasound. And I tried to find the answer, and I don't know. So it's definitely a piece of uncertainty. So I'm going to have to take a leap of faith, and I'm hoping that our discussant is going to tell me about an ADAM-TS 13 activity level, and I'm really hoping that it's going to be severely reduced, because I think our patient has pregnancy-associated TTP. All right. Thanks, guys.
That was fantastic. Great. So with that in mind, I will now introduce our discussant. This will be Dr. Bharadhwaj Kolipakkam. He is a hematologist at the VCU Massey Cancer Center as a member of the Division of Hematology Oncology in the School of Medicine at VCU. He completed his medical training at Chengalpattu Medical Center in India and completed internal medical residencies both at Kolipakkam Medical College in India and Virginia Commonwealth University here in Richmond. Following the internal medicine training at VCU, he completed a fellowship in Hem-Onc and joined faculty at the Massey Comprehensive Cancer Center, specializing in benign hematology and lymphoma. All right, and I will invite Dr. Kolipakkam to come right up.
Right. I'm really excited to be here today because it wasn't too long back that I was a resident enjoying CPCs. This is definitely one of the fun parts of the grand round. So thank you, Pat. And what a phenomenal presentation, Dr. Paletta-Hobbs. Pat was kind enough to warn me because of my tendency to talk a lot that I have only 15 minutes. So I'm going to put on a timer here just to make sure. All right. So this is a really great case for CPC because pregnancy-associated TMA is a really hard, complicated, high-stakes evaluation diagnosis because time is of essence when it comes to diagnosis and management. So as had been discussed, so thrombotic microangiopathy is a clinical triad of microangiopathic hemolytic anemia, thrombocytopenia, associated end organ damage. Pathologically, it is characterized by endothelial cell injury and microvascular thrombosis. And of course, the classical schistocytes that we see in the peripheral smear as a consequence of the microangiopathic process. Why is it important, especially in pregnancy, to evaluate quickly and make the right diagnosis? Because pregnancy and postpartum period is a high-risk period for various forms of TMA. Because of changes in the pro and angiogenic factors, immune changes that are related to pregnancy, and because pregnancy is a known driver of complement. And it is associated with significant morbidity and mortality, both for the mother, but also adverse outcomes for the fetus, including stillbirth and IUGR. And as I mentioned, decision is time sensitive. So I break down the TMAs as those that are specific to pregnancy and those that are seen in non-pregnant women as well. So pregnancy-specific ones are preeclampsia, HELP syndrome, which we think of as a continuum, acute fatty liver of pregnancy, and severe postpartum hemorrhage. And non-pregnancy specific ones are TTP, complement-mediated TMA, which we used to call as atypical HUS, SLE and associated catastrophic APS, DIC, and the other causes as were mentioned. So the incidence of TMA in pregnancy in general is about 5.5 to 6%. But the bulk of that is preeclampsia. And that's why we think about it right off the bat. So you can see that it's about 1 in 20 women, 1 in 20 pregnancies. HELP is a little bit less. The other ones to be mindful of are acute fatty liver of pregnancy. But as you can notice, complement-mediated hemolytic uremic syndrome and TTP are quite rare. So I'm not going to dwell too deep into these because such a good presentation was just done. I will just highlight a couple of things here. HELP syndrome can be seen in people who have other causes of TMA. So just because somebody has TTP or atypical HUS doesn't mean that they are not having or they cannot have HELP. So it is important to recognize that that is an important piece to how we think about this question. And also the time that we see this is important, because if you are seeing a patient who is outside of that window, then generally you can rule that out and start thinking about other differentials. So we think that preeclampsia HELP is primarily due to abnormal placentation, whereby there is an imbalance between the angiogenic and anti-angiogenic factors. And so one of the newer tests that have come up recently is the ratio of the soluble FLT1 to PLGF, which is the placental growth factor. I'm not 100% sure if we have it here yet, but it does seem to be helpful in the diagnosis of preeclampsia. Acute fatty liver of pregnancy is another rarer conditions of TMA, which usually is seen in the 3rd trimester, characterized by elevated liver enzymes, coagulopathy, and it's thought to be due to defects in the lipid metabolism, but can, as I mentioned, coexist with PE and HELP. Now, pregnancy-associated TTP can be seen in about 10 to 30% of all adult cases of TTP, and as was discussed, is a deficiency of ADAMTS13. So ADAMTS13 is a nice cleavage protein. So von Willebrand factor is made in a large volume because that's the most efficient way to manufacture it. But once it's released from the endothelium, you want something to cut it up into small pieces, thereby it doesn't trigger the platelets to get activated a lot. So you have these cleavage proteins called ADAMTS13, which get into action immediately as soon as it gets into circulation. Thereby, it cleaves the ultra-large von Willebrand factor multimers into smaller portions. Thereby, it can do its job of activating the platelets. But when you have a deficiency of this protein, either because there is a defective production because of gene defects, or there is an antibody that is made against this protein, then you can have these large multimers that are released into circulation. And this is kind of like a large conveyor belt, which is extremely sticky. And so when platelets stick onto them, you have a huge activation of platelets and you have microthrombi formation. And the red cells pass through it, they get sheared. So, and because of the ischemia that happens due to the process, it can affect various organ systems, as was discussed. So the primary organs that are involved are CNS, GI, cardiac, and kidney. So the pregnancy causes some changes that makes it a little bit more conducive for development of this condition. So pregnancies changes generally tends to be, as you go on through the pregnancy, to be prothrombotic. And that's by design, because once the delivery happens, we want a mechanism for the bleeding to be stopped. So as the pregnancy proceeds, we see that the von Willebrand factor actually goes up. And ADAMTS13 levels actually don't go down by the production part. It's just that there is so much of von Willebrand factor that is being made that it decreases relatively the ADAMTS13 levels. And the other factor is that there is immunological mechanisms in play when pregnancy is ongoing, because we know that pregnancy is a quasi-immunosuppressive state for protecting the fetus. And then once the delivery happens, there is a spring effect where there is an immune rebound that happens. So that also can play a role in autoimmunity, as we would see with many other autoimmune conditions postpartum. So, so the presentations, as we discussed, the diagnosis happens usually with the levels, and we also want to check the antibodies to make sure that it is indeed an autoimmune process. And management consists of plasma exchange to remove those proteins and immunosuppression so that those antibody production is decreased. Whereas in congenital TTP, we would do plasma infusions as prophylaxis. And now we actually have a recombinant ADAMTS13 that can be given in such cases. So the other big differential with TTP is atypical HUS. Typical is because that was initially primarily recognized in the setting of the dehydration secondary to food poisoning from the E. coli infections. But atypical HUS, as was mentioned, is a bucket term, but we now prefer to use the word complement-mediated TMA because we think many of those conditions, including pregnancy-related HUS, is a complement-mediated process. It is a diagnosis of exclusion, but we can sometimes send off these complement pathway proteins to see if their levels are decreased or impaired. The genetic test is available, which helps us to identify a predisposition for complement activation to be in overdrive, but they can take time and they're not definitive, which means that if the test is negative, it doesn't rule out the diagnosis. So it may help retrospectively, but it doesn't really help in the thick of things. And the management is with anti-complement pathway. So it's important that we have a good approach to our TMA patients in pregnancy, because there is an urgent need to rule in or out the pregnancy-associated TTP. If we don't, the mortality rates can be pretty high, upwards of 80% in untreated cases, whereas it can go down to less than 10% if we treat it promptly. And the other reason is because complement-mediated atypical HUS or TMA requires treatments to be started soon. Otherwise, the kidney impairment can become permanent. So the other practical considerations that come in is that ADAMTS13 is not a test that is available in-house, and so you would have to send it out. And we don't get the results at a minimum 2 days, potentially 4 days. So there is a time delay where you can't afford to wait for the test result to come back to make your decisions. And as mentioned, complement-mediated TMA, it's a diagnosis of exclusion. So we look at some clues when we are evaluating a patient based on history and examine lab findings to determine if we can get a clue to find out which way it is headed. So the timing of TMA is very important, coexisting symptom, lab work, and then you look for a probability-based assessment for cause. So as mentioned, the pregnancy-associated TMAs, which is HELP, preeclampsia HELP, and the acute fatty liver of pregnancy usually occurs between 24 weeks of pregnancy to 72 hours postpartum. So if you're in that window, then all bets are off. You're looking at all the possible differentials. You would still, if you have to throw a dart, would throw it on HELP, but we recognize as a part of CPC that that's not the right way to do it. But If you're looking at a patient before 20 weeks, then the chances that this could be a TTP or complement-mediated process is a little bit higher. TTP actually is a little bit more common in those settings. And in postpartum, especially if after 72 hours, we note after delivery, if we note that things are not getting better, again, TTP, atypical HUS come into the differential, and you would think more about complement-mediated TMA, especially if the kidney function is getting worse. So this was put very beautifully. I think mine is a little bit more simpler, but basically look for thrombocytopenia, kidney impairment, and of course, the ADAM-TS13 level will help us guide going forward. And this is a really beautiful pathway walk to think about when we have a patient with TMA in pregnancy, but I'm going to break that down. So first step, confirm that we actually are having a TMA. So we need to make sure that we have a microangiopathic hemolytic anemia, which by definition is non-immune, so the DAT should be negative. We should be looking for confirming hemolysis. So we are looking at the reticulocyte count, we are looking at haptoglobin, LDH, and bilirubin, and then we need to show that there is RBC sharing. So that would be in the form of schistocytes and thrombocytopenia and peripheral smear. And then we think through the process in the order of common, dangerous, should act fast. So common is PE. So you're thinking about checking the blood pressure, UA, liver function test, and the ratio of the angiogenic factors. You want to rule out TTP, it is dangerous. Send off the activity and antibody, and then use the plasmic score. And then if we think that there is a relative high risk, you pull the trigger on doing a plasma exchange. And then we can continue our workup, because that's very important. Then we look for other causes, sepsis, DIC, look for any history or evidence for autoimmune process, any drugs, infections, and never forget about B12 deficiency, because B12 deficiency is kind of like a pseudo TMA. It's not literally a microthrombotic process, especially if you have a reticulocyte count that is not elevated. Think about B12, B9 deficiencies, because we've had a few patients who have had those presentations. And then complement-mediated process is a diagnosis of exclusion. So you want to consider that, but always keep an eye on the kidney function. So going back to our patient, we showed that we got the results back, and the ADAM-TS13 level was 6%, which is less than 20 that we keep a threshold for. And so she was started on plasma exchange for about 4 days. We also got prednisone 1 milligram per kilogram daily for immunosuppression. And then we can see that 5/21 was when she got the plasma exchange started. So the blue is the hemoglobin, the red is the platelets. So we can see with initiation of the plex, the hemoglobin levels started rising up, and so did the platelets. Now, the initial bump in platelets was because a platelet transfusion was given. And similarly, looking at the other parameters, the creatinine, okay, my time is up is what it says. So the creatinine goes down, the LDH goes down, and the haptoglobin goes up. So seems to be working well. And the ADAM-TS13 level that was obtained post 4 days showed that the levels had gone up to 35%. I'm going to skip this for interest of time. But it's important to recognize that low ADAM-TS13 level is the initial part of the process, and we've initiated the process. But we would need to continue management with plex, which is usually a stopgap. In many cases, we also want to do immunosuppression to make sure that the antibodies don't come back if it is an antibody-mediated process. Because we have another differential for that, which is congenital or hereditary TTP, where it is more of a production issue. And it is important to think about that because it is found that pregnancy can be the first presentation for congenital TTP in a significant number of patients. And so in this patient, we actually found out that her antibodies were actually negative. And then we did a genetic analysis, which showed that there was biallelic pathogenic variants in the gene. And so her final diagnosis is actually congenital TTP. So great. We saved the patient. So any questions? I'm sorry I rushed through in the end. Yes, Dr. Kidd.
You went by real quick, but I think we're fortunate sometimes to have these labs available to us. So what would be things like, let's say you can't get an IMCS for feedback for.
Right, and I think.
Can you repeat the question for those online?
Yeah, no, the question is, sometimes in big institutions, we have the luxury of getting those tests sooner, whereas sometimes we can't get the tests quickly. So what do we do? And I think that is where the application of the clinicopathological features becomes extremely important. And when the degree of suspicion is high, after we think about the process and we use the plasmic score, the immediate step should be to initiate plasma exchange as we are doing the evaluation and send off the levels. Ideally, if we are in an institution where we don't have that facility, we should be sending the patient to a place where they can do a plasma exchange because it is of essence. As was mentioned, about a third of patients may not have neurological symptoms. And in our patient, there was no neurological symptoms, which is good, which is what we want, because if we don't do anything, that's where eventually it will end up, and that's really bad for the patients. So I think to answer your question, I think the important thing is to have a high degree of suspicion and then pull the trigger on plasma exchange if we feel that the risk is high enough as we are doing evaluation for the other causes. But usually we should be seeing the improvement pretty quickly with plasma exchange. So one of the clues that can be obtained is if we notice that the kidney function isn't improving at all, and then we get an ADAM-TS13 level that is low, then the immediate thought process should go towards complement-mediated TMA, especially if it's postpartum, especially if the platelet levels are not low, as was in this patient's case. The low platelets of 9,000 is much more common with TTP than we would see with complement-mediated TMA. So I think those factors come into play. Hope I answered your question. Yes. Right. Yeah, that's a great question. And I think, again, for interest of time, I skipped through. I think one of the reasons why we see these becoming important in pregnancy is because it's a state of high endothelial burden, if I may put it that way. The reason why we see kidney dysfunction significantly in complement-mediated TMA and in TTP sometimes is because it's an organ rich in endothelium. So I think that is one of the main reasons why we see these impacting the uterine system and the placental system, because it's extremely sensitive to ischemia. And so when you have, when they look at the pathological specimens of the placenta in patients who have these TMAs, they see that there is a heavy burden of complement deposition in the placenta in like post-delivery when they do a pathological assessment. So I think that is one of the main reasons why we see that the placental unit is affected when you have TMA.
Another question.
Yeah,
Thank you.
okay, we have.
No
Okay.
specific questions. Well, thank you all so much. Appreciate it. I'll get the CME code up here in a second. Thank you so much.
Thank you.
Oops.